All right. Welcome, everybody, to the July 9th, 2025 Oregon Healthcare Workforce Committee meeting. Next slide. And I'm Ian Strauss. I use he, him pronouns, and I am the chair of the Healthcare Workforce Committee and will be facilitating the meeting today. Next slide. Just a little bit of housekeeping. This meeting is open to the public and will welcome public testimony as part of the meeting. The meeting will be recorded, live transcripts will be available. And if you are on the committee, please turn on your camera if you're able, so that we can see you. Otherwise, next slide. Okay. Now, as requested by the Oregon Health Policy Board, we are going to call roll call for committee members. So please let me know you're here and you can give us your name, pronoun, and organization that you're affiliated with. Let us know you're with us. Aaron Hines. Elena Shablasky.
Hi, sorry, it took longer to find the mute button than it usually does. My name is Elena Shablatsky. I use she and her pronouns, and I'm a dental director and dentist at La Clinica, which is a federally qualified health center in Southern Oregon.
All right, well, welcome. Alicia Jackson. Koi Vu.
Hi, everyone. Koi Vu, pronouns she, her, hers. I'm the executive director of the Coalition Community Health Clinics.
Well, welcome. Eric Weiser. Gabriela Carrillo. Gretchen Horton Dunbar. Here, Jason Johnson. Judy Geiger.
Hi, I'm Judy Geiger. I'm a recently retired registered nurse. I've been a registered nurse for over 40 years. My most recent job was as the chief nursing officer at Columbia Memorial Hospital in Astoria.
All right, well, welcome. Kelly McKnight. Larissa Mejia Medina. Laura Chan.
Hi, my name's Laura. I use she, her pronouns, and I'm a fourth year of med student at OHSU.
All right, well, welcome, Laura. Levi Anderson. Okay. Dr. Weiser, we're doing roll call, so we're just your name, pronoun, and where you're associated with.
Sure. Eric Weiser, pronouns are he, him. And I am faculty at OHSU, but also the director of the Oregon AHEC.
All right, well, welcome. Manu Chaudhry. Megan Holland.
Hi, Megan Holland, she, her pronouns. I am a family doctor, chief medical officer at Coquille Valley Hospital, critical access hospital on the South Coast, and regional associate dean for the campus for rural health for OHSU.
All right. Well, welcome. Molly Reynolds.
Good morning, everyone. I'm Molly Reynolds. I use she, her pronouns, and I'm a program manager with the Care Pathways program at Rise Partnership, supporting home care workers and personal support workers. And I just want to let everyone know my camera's going to be off today just because I had a very late night of travel and I'm recovering. Thank you.
All right. Welcome. Rob Ross. Bob Lieberman. Bob Hemmings. Or, excuse me, Dr. Hemmings.
Hi, good morning, Dr. Rosemary Hemmings. I own a behavioral health group mental health practice in Beaverton. I use she, her pronouns, and just full disclosure, I am also on Oregon Policy Board.
All right. Welcome. Stephanie Grayson. Surya Karlapati. And Tessa Christensen. See Tessa's on the call. I think there's sound issues. Okay. Okay, I believe that gives us quorum for this meeting. Jessica, next slide. Tessa, we see you, so don't worry. Okay, so guests and OHA staff, we welcome you, and if you would put your, your name in the chat so that we can recognize that you're with us today. Next slide. Okay. We do want to thank all of the incredible folks from the OHA who support this work and who have been part of what we're doing. Here's a list of at least some of the folks who we know are on this call. So thank you, all of you. Next slide. Okay, we have ourselves a pretty busy meeting today, quite a lot going on. We're going to start off by reviewing and approving the meeting summary from our May meeting, looking at public comment, a quick update from the Oregon Health Policy Board and the OHA updates, and then we'll get some information on the New Brookings Dental Clinic. We'll get information on the temporary healthcare staff rate setting program, the Oregon Partnership State Loan Repayment Program overview, and then information after the break, we'll go into behavioral health land and be talking about the Qualified Mental Health Associate Pilot Program and an in-depth look at the Oregon Licensed Behavioral Health Workforce from the data program. Anyway. Okay, next slide. So because it focuses all the work that we do and overlays what we're doing, we like to review the health equity definition. So I will go next slide. Here, let me read this just so that we all have it present for us as we move into this meeting. So the Oregon Health Authority, Oregon Health Policy Board Health Equity Definition. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So once again, this is the framework that all the work that we do sits inside of. Next slide. Now, these are questions we have for around the equity framework to think about it. I'm not going to go over each individual question, but please be aware of them and take some time to look at the presentation and look through this to see how we're applying the health equity framework to the work we're doing. Next slide. Okay, so we sent out with the materials for the meeting our May meeting summary. Does anybody have any comments, updates, changes, or concerns for that meeting summary?
Hi, Ian. This is Deepti Shinde from OHA. Doing a count of the committee members, I actually only count 10, and we need 12 for quorum. So we have not gotten there yet.
Okay. So why don't we, let me just make sure, I think you are as likely to catch that than I. Why don't we put this off till later until the end of the agenda? And that way we can keep rolling. Next slide. Okay. Where are we? Are we at public comment or were
We're
we?
at public comment, I do believe.
Got it. Got it. Okay. Do we have any public comment today?
Question. Sorry,
Yeah.
question regarding the quorum issue. So you can proceed with the meeting, but you can't take votes, or you're not allowed to proceed with the meeting if you don't have quorum?
My understanding is we can't do voting. Anybody else? Anybody from the OHA, OHPB who have?
That is my understanding. This is Jessica Mills from admin support, that we can still have the meeting, we just can't vote on anything.
Yes, that's correct.
Okay. Good to clarify. Thank you. Okay. So we go on to the next slide. Let's see, where are we? Nope, keep that there. Okay, public comment. So I'm not hearing any public comment. Is there anybody else in the meeting who wants to give public comment today? Okay. Oregon Health Policy Board updates. Melina?
Yeah, good morning, everybody. Melina Moran, she, her. I am the liaison with the between this committee and the Oregon Health Policy Board committee. Currently, we have 7 seats, and the upcoming September 2nd meeting, hopefully we'll have 2 more appointees appointed at that meeting. Also, I'd like to mention that August 5th is our next OHPB meeting. This will be held in Medford. And on August 4th, we have a site visit. This will be at a local behavioral health provider organization. In our last meeting on July 1st, we had an OHA update. So most of the update was discussing the OHA's federal response and their planning team. And they discussed that OHA is closely monitoring the changes out of DC, monitoring any changes that will affect Oregonians, any executive orders. There is a upcoming webinar on July 22nd, and this is with the OHA and the ODHS to discuss further. There is a federal response website so that you can reference that has a lot of really good information. There are some current federal funding impacts for Oregon. There was a $117 million termination in grants that we currently receive. This was blocked in a lawsuit, so we are continuing to receive those funds. We're waiting to hear about the federal 2026 budget proposal. And so the key point here is currently there's no changes with OHP at this time. There are some key impacts with the new reconciliation bill or the HR 1 bill. There'll be changes to or potential changes to the marketplace. The monthly premium can increase. This can prohibit, there's also can prohibit some people from enrolling in the marketplace regarding their immigration status, and potential removal of coverage for gender affirming care. And there can be changes to the basic health plan. Again, OHA is monitoring the impacts on Oregon. During this legislative session, OHA budget increased 16%. And this is in consideration of the possible changes. So we are continuing to fund Healthier Oregon, funding, protecting reproductive rights, and many other protections. We heard reports from some of the subcommittees. The OHPB hears the subcommittees updates 2 times a year. So we heard from the Medicaid Advisory Committee and where they are on the 1115 waiver, focusing on health-related social needs. We also heard from the Public Health Advisory Board. Currently, they're working on revising their bylaws and their charter review. They're working to modernize their public health plan, their workforce plan. They're looking at this through equity framework and aligning their metrics and their goals with OHPB's. We also heard from the Health Insurance Marketplace Advisory Committee. This is the marketplace for people in Oregon who don't qualify for Medicaid. And their goal is strengthening access and affordable healthcare for all. Next, we discuss the Coordinated Care Organization procurement update. This was the first update since the report. So House Bill 2205 passed, and so it no longer requires legislative action to alter the contract length. So OHA extended each contract from 2028 to the new. It will be renewed in 2029. Currently, they're working on clarity of the CCO expectations. They're collaborating with community. They're identifying key measures, and they're doing a full landscape scan and gap analysis. Next, we heard about evaluating consumer voices in the Quality Incentive Program. This is bonus dollars for CCOs. The benchmarks for the specific measures will be reviewed. And then next, and finally, the OHPB priority work will continue to be discussed. We have an upcoming retreat in August. And like I said, our next OHPB meeting is August 5th in Medford, and it will be hybrid, and we welcome anyone to join either in person or online. Thank you. Are there any questions?
Okay. Well, thank you, Melina. OHA updates will be in writing, I believe, attached to the minutes of this meeting. Deepti, Neelam, anything you'd like to add for today's meeting?
Yeah. Hi everyone. Neelam Gupta, she, her pronouns. I'm in clinical supports integration and workforce here at OHA. Jessica, would you mind advancing 2 slides? So wanted to make you all aware of upcoming committee activity happening next month. You should have received invitations yesterday for 2 meetings happening on August 13th. First, we're going to start with an educational webinar on nursing workforce. That'll be 9 to 10 a.m. And that attendance is optional. And that will be recorded like all of our meetings and available on the website in case you are not able to attend. This is part of our ongoing effort to provide educational webinars in the even-numbered months. And then secondly, we are also scheduling a special meeting from 10 to 11 a.m. And that meeting's purpose is to approve the distribution of monies for the 2025-27 biennium, which started on July 1st. And that will be an approval vote. I know that we very recently approved the evaluation, and this is another responsibility of the committee, and then we will go to the September 9th Oregon Health Policy Board meeting for the approval, so we can start distributing those funds.
Okay. Thank you, Neelam. So again, important we get quorum for that meeting. The impact of not making that meeting in terms of being able to do that vote is that that funding can't be distributed until we vote on it and then the Oregon Health Policy Board votes on it. I believe that then puts that out into November or something if we don't make it at this point. So a very strong please if you can attend that meeting on the August the 13th at 10 o'clock so that we can get that vote completed. Okay. Anything else from OHPB or OHA? I can let everybody know, we talked a few meetings ago about the direction the committee is going, and I had agreed to talk with members of the OHPB leadership. We had that meeting, and while nothing has been voted on, I can let you know that they're talking with the OHPB leadership. Their thoughts were that they would like to see us looking at primary care, which includes dental, behavioral health, social determinants, as well as medical care. And that we also look at our work in combination with some of the work from other committees. And so we'll be continuing that conversation as a committee moving forward. Okay, next slide. Any questions, by the way? Okay, so we're now going to move on to the new Brookings Dental Clinic update. John McElfresh and Laura McKean. Welcome, Laura and John.
Thank you. Good morning, everyone. It's nice to virtually see everyone again. John, are you taking the first slide?
Yeah, Laura, I'll take the first slide. Thanks. Hi, everyone. My name is John McElfresh. I'm the Oral Health Workforce Coordinator for the Clinical Sports Integration and Workforce Unit. And apologize, I won't be on camera today. I'm having a tough time sitting or walking this morning. But I was really lucky to be a part of this project, and it was certainly one of the most significant achievements accomplished using resources from the 2018 HRSA Oral Health Workforce Grant. As many of my colleagues know, the purpose of the grant was to improve recruitment and retention rates and increase training opportunities for Oregon's oral health providers and subsequently expand oral health access for Medicaid patients. And grant itself focused its resources on specifically targeted underserved areas where studies showed there may be a general lack of infrastructure to support oral health services, access problems for the area's residents, or historically a difficulty recruiting providers to serve Medicaid patients. Now, initial analysis of Curry County from various reports and site visit feedback from the latter part of 2018 showed that this area had many of the aforementioned issues and merited a greater level of resources from the state. Now, with a lot of projects aimed at improving oral health access, this project took several years to bring to fruition, as evidenced by the fact discussion between Oregon's primary care office and All Care CCO on how to mitigate some of Curry County's oral health issues began back in early 2019. Now, over the years, this framework for the project went through several different iterations, initially beginning with working with a local dental care organization to expand the operations for their teledentistry team and to integrate dental services into the office of a local FQHC. This initially began with rendering service in a tiny converted bank vault, but due to the limitations we experienced later on, we were forced to pivot and explore how to subsidize costs to co-locate a dental clinic and a local behavioral health or primary care clinic. Unfortunately, the project wasn't sustainable and never materialized due to a lack of bandwidth from local organizations or the finite amount of resources that were available from the HRSA grant. Ironically, it was the COVID-19 pandemic that ultimately helped bring this project to fruition because grant operations were suspended during 2020 and a large part of 2021. We had a large amount of unobligated grant funds we were able to carry over to subsequent years and allocate towards this initiative. Now I'll pivot over to you, Laura, to talk about how we finally succeeded in bringing this to life.
Sure, thank you. I also think, first of all, Laura McKean, I am a quality of care analyst with the Operations and Medicaid Division here at OHA, formerly with All Care CCO for 11 years. And I think it's also important to mention, John, that, while COVID allowed the grant funds to be utilized, it also stalled us a little bit. But ultimately, like John said, we were able to bring this to fruition. Can you go to the next slide for me? So what we did, this is a picture that this is a pretty proud picture of John and I at this clinic. So what we did was the CCO and OHA partnered with an entity called Equity Dental, and we co-located this dental clinic inside a federally qualified health center called Coast Community Health in Brookings. And they totally gutted and remodeled this, the downstairs of this building. It used to be a surgery center owned by Dr. Rush and Brookings, who did day surgeries for many, many years there. Then it was bought by Coast Community Health, and it was turned into a health center that was very active in COVID, by the way. They did a lot of COVID immunizations and healthcare. But once COVID was over, needed to pivot a little bit, as John said, and do something else with the building. So Equity Dental came in and said, hey, we realize there's a need. We have a provider there and we want to put a dental clinic in that downstairs. And so the grant helped with putting that clinic together. Like I said, they gutted and remodeled the entire practically downstairs to put in, I believe it's 3 dental chairs. There's a lab, there's front desk. They have a dentist, just recently hired a hygienist. They have dental assistants and a front staff. But we're just really blessed and fortunate that the grant funds were available to subsidize a lot of the costs for this, a lot of the equipment costs, the provider recruitment. I am pretty confident that without the grant funds, we would not have been successful in this, as well as Equity Dental also put in quite a bit of funds for this. So here's a picture that we took. This was again a collaborative effort. There were so many partners that were instrumental in getting this clinic open. On the far right is Dr. Pete. He's the dentist there, and there's project managers. On the far left is Dr. Shirtcliffe, whom some of you might remember. He was actually the founder of Advantage Dental. He's now retired and president of Equity Dental. And so the CCO All Care was able to contract with ODS Dental, or MODA, Oregon Dental Community Services, and they ultimately contracted with Equity to provide these services in Brookings. And I think if we can, there's like a 2-minute video. Maybe 2.5-minute video we wanted to show. Is just an informational video on a little bit about the area and how the clinic came to fruition, and also, really good testimony of Dr. Pete and what this has meant to him. So if we could do that, Jessica, if you can make that happen, that would be awesome.
Is that just the link there on the screen?
It is.
Yeah, I think we have time for that today.
Thank you. I appreciate it. You do? Did you say yes, Ian?
Yes, we do.
Okay, perfect. Thank you.
And before we begin, I just would like to say, I think everybody on this call and the people in Curry County just really need to commend Laura, because OHA and the grant was just a little cog in the wheel. And honestly, back in 2023, after 3 failed attempts, I almost gave up and pivoted to another area. But Laura pushed on. She was diligent, researched other opportunities, and
I wouldn't let him
without
quit.
you, Laura.
I wouldn't let him quit. We're not hearing anything, Jessica. I think there's a setting that you have to do in there to play it.
Maybe if I just unmute myself, because I'm just sharing my screen.
Maybe
Here, I can restart.
There should be like a little checkbox when you say share screen that allows you to share audio too.
Pete Lottie,
Yes.
Dr. Pete Lottie.
Were you hearing him?
We are now.
Okay.
I grew up in Lincoln City, Oregon, and so that makes me a coastal boy for pretty much for life. After high school, I went to Lewis and Clark College in Portland, Oregon, where I met my fiance, and then I went to dental school at OHSU in Portland. And then I took my very first job, which is here at Equity Dental in Brookings. And it's been a great place to grow, and it's been just an awesome experience so far. The procedure mix that we do, it's a lot of different things. I mean, we practice general dentistry, so that means that pretty much anything that I'm comfortable with, I'm allowed to take on within reason. So we do anything from fillings, extractions, root canals, crowns, some aesthetic work, and kind of anywhere in between. And we see from about 1-year-old to my oldest patient probably today was 90. Technically, I am an employee of Equity Dental. They hired me as an associate dentist pretty much to run this practice for them here in Brookings with with the help of, a lot of different dentists. I have a lot of help behind me, a lot of dentists that have been doing it for a long time, and even on the back end, insurance, billing, and whatnot. So yes, I'm technically an employee, but I do run the practice, and I get help from a lot of different people, which has been so helpful, especially being a new grad, being able to have a network of dozens of dentists behind me. It's definitely, it gives me a lot of comfort and a lot of confidence. Actually, the idea for this clinic started before I even started dental school. And it was an uphill battle just to be able to get this up and running. But between the efforts of those at Equity Dental and also the Oregon Health Authority giving us a big grant to be able to get this clinic up and running, it was really a team effort from start to finish. And I was kind of the last domino that fell into place. And the mission from the start was to be able to increase access to care to patients that are on the Oregon Health Plan or Medicaid. Prior to us being here, there was only one other clinic in town that saw Medicaid patients. And there's thousands of Medicaid patients, and it's hard when there's a single provider seeing that many patients. So being here has increased access to care tremendously. It's been nothing but great. People are so grateful. I get thanked probably a dozen times a day just for being here. Just being able to give people the access to care when beforehand they may have had to wait months for care. We do focus on Medicaid patients, but it's been the same for private pay, cash pay, anybody. But in a place like this, it's hard to have enough providers, period. So I've been welcomed with open arms for both other dentists and every single patient. I know how it could be traveling to get care. It's hard for a lot of people. And it's even tougher in a place like Brookings, where a lot of the nearest specialists are 2.5 hours away. And, every now and again, it still comes up where people do need to travel for specific reasons. But I try to keep as much in-house as we possibly can in getting people in on a timely manner so they're not in pain. And that's actually one of the things that we take really big pride in, is not only seeing people and giving high quality care, but also trying to do it in as timely of a manner as we possibly can. The support staff from start to finish, from Equity Dental to All Care, and I couldn't have asked for a better staff, seriously. So sorry, I get a little emotional. Sorry, I wasn't expecting that. It's been a great place to be, and I feel very blessed to be here. It's been fantastic.
Thanks, Jessica. And again, thanks for letting us share that. It's sometimes we look at that and we've been a part of the work for so long. It's kind of hard not to get emotional when you look at things like that, just because we work so hard and we know the care that we're providing those people is just it's just so important. So again, thank you. Thanks to everyone for letting us share. And thanks, John and Neelam, for hanging in there with us for the last 6 years, and everyone that was involved.
All right. Well, thank you for sticking with it. Committee members, any questions for John or Laura?
And I was going to say, Judy, I just saw your comment, and he is actually my dentist. I actually drive to Curry to see him because he started being my dentist, and he is wonderful.
Okay. Well, thank you both. And let us move on to the next slide. The Temporary Healthcare Staff Rate Setting Program overview. And I believe that'll be Joe Sullivan presenting today.
Oh my goodness, there we go. I am here. Thank you for the introduction. I appreciate it. And first and foremost, thank you to everyone for giving us a moment of your time and the opportunity to share a little bit about what our team does today. We're hoping that this will just serve as an introduction to what we're doing. Real quickly, before I get started, I just want to introduce my team members, some of which are on the call. So again, my name's Joseph Sullivan. I use he, him pronouns, and I'm the manager of the Temporary Healthcare Staff Rate Setting Program. Rodney Manelis is our policy lead. Shelly Huber is our implementation lead. Brian Lothrop is our research analyst. And Claire Scholes is our project manager. All right, so perfect. We're on the slide. We can go ahead and leave it here for a second. So jumping into the bill. House Bill 2665 is from the 2023 session. And what it does is it directs OHA to adopt rules and set maximum billable rates that a temporary staffing agency can charge a hospital or facility for certain personnel. The personnel that are impacted by this legislation are RNs, LPNs, CMAs, CNAs, and direct caregivers. The legislation creates rules that govern the temporary healthcare staff rates and includes a waiver process for emergency and non-emergency critical events. These waivers allow for TSAs to charge over the maximum rates for a set limited duration. We also receive data related to the temporary staffing agency rates between the TSAs and facilities and have a mechanism to forward complaints over to the Health Licensing Office for enforcement. We are required to do an annual review of these maximum rates. And that's going to be important for later in the meeting because we have an annual review process, means that we hold a rule advisory committee every year as these rates are embedded in rule. This gives us a really unique opportunity to continue to address unintended consequences and build a program that is responsive to the needs of folks who are impacted by it. Next slide, please. For folks, just for a heads up for folks, if you wanted to take a deeper dive into the rules, our rule section is the 409039s, and they're really set out to establish these maximum rates, as I mentioned before. And the different entities that are impacted by the legislation are in ORS 676716. And you can dive deeper into that if that's your prerogative, but that is not why I'm here today, so I won't dive too deeply into the OARs. So next slide. Overarchingly, as a program, we have chosen to operate with 3 guiding principles. We do our best to ensure that these 3 guiding principles are centered in all of the decisions that we make and how we operationalize the program and how we interact with the folks impacted. We recognize that not everyone has had a seat at the table, and we have to strive to mitigate power inequities that exist between the 3 primary groups impacted by the legislation, which are the workforce, the temporary staffing agencies, and the hospitals and facilities and their representatives. Obviously, folks on this call are keenly aware that there is difference in power that each of those groups hold, so we do our best to try to mitigate those power inequities and create opportunities for input for all groups. We're also striving to minimize workforce disruptions. So this legislation, because it puts a cap on the maximum billable rates, does have potential to create some workforce disruptions. And we recognize access to care as our North Star and work to ensure that the way we operationalize the policy allows for the workforce and the TSAs and facilities to negotiate rates to meet the needs of all 3 parties. So the rates are set high enough for folks to be able to kind of have some movement within that process and don't set the cap too low where everyone is kind of butting up against it. So we strive to create a program that doesn't disrupt that workforce dramatically. Lastly, we view our whole program as an iterative process. As I mentioned earlier, because the legislation requires us to do a yearly review, we have this unique approach to policymaking in front of us. It's one that gives us ample opportunity to listen to the needs of folks and then be responsive to those. Because of the need to do rules and rates yearly, we're working through iterations and will continue to be responsive to the things that we hear from folks impacted by this bill. Right now, we're working on calendar year 2026 rates. So rates have been effective for 7 months. Our program started on January 1, 2025. New rates will be released later this year, and those will be effective January 1, 2026. And that's the big body of work that we're working towards right now. Next slide, please. All right, and how this relates to the workforce. So first and foremost, just want to make sure that I highlight one piece of information, that these rates always start with BLS OED data. The legislation requires the rates to bear a reasonable relationship to OED data, so we will always start there. And we're just following the data in terms of setting those rates from that starting point with BLS and what it tells us. We launched the program on January 1, 2025, and we've learned a lot of different things, but most importantly, from a workforce perspective, is that we received 14 waivers. As I mentioned earlier, those waivers are a mechanism for folks to be able to charge over the maximum rates to place staff during an emergency or non-emergency situation. Providence Health and Services had that labor strike earlier in the year, in which case they had to utilize the waiver process in order to land the staff that they needed to fill those temporary vacancies. We also heard from one TSA, one temporary staffing agency. My apologies for the acronym. We learned from one TSA that they will no longer be working in Oregon, and they cited the temporary healthcare staffing rates as one of the driving factors to choosing to no longer service in Oregon. I think that's an important piece of information, as that's one thing that we're working to try to avoid, is having too many TSAs choose not to place temporary staff in Oregon. Of note, there are 287 active licensees in the state, of which we have a record of over 100 or around 150 that actually placed staff in 2020. We have not received any word or heard of any labor shortages attributed to the program or the maximum rates as we have set them this year. So next slide, please. All right, so why am I here? It's probably the question y'all are asking as I share a little bit about the program. And one is to just give you a little bit of familiarity with what we're doing and the legislation that exists within the larger workforce paradigm that NELUM oversees. And the other is to help us create a more robust Rule Advisory Committee process this year in 2025. So we held our Rule Advisory Committee process, or a RAC, in 2024 and had limited representation from the workforce, which led to an incomplete voice in the rulemaking process. We recognize that as being contradictory to the guiding principles we have for our program and leading with equity. And so we view that as something critical to creating a more robust experience in 2025. We're really looking to enhance workforce representation. And again, this is key to us being able to get over the hurdle and work through the obstacle of the lack of workforce representation, leading to the inequitable input in our processes. And that's exactly why we're here today. We would like to try and engage this impacted population in a more effective way, and thought the Healthcare Workforce Committee might be an avenue towards helping us do some early outreach. Next slide, please. So the ask that we have is that we need your help spreading information, or would like your help spreading information about the opportunity to participate on our Rule Advisory Committee process. So we seek members of TSAs, workforce, as well as hospitals and facilities, but we already have a robust list of facilities and TSAs because they're licensed through our different bodies. So we're able to draw from the licensing information. So we feel like we're pretty sewed up there. But the one glaring gap, as I expressed earlier, is the workforce participation. That being said, if you have other contacts that might be interested from hospitals or facilities or temporary staffing agencies that we may have missed, feel free to share this information with them as well. But what we're really asking for is, if you have workforce members, we're striving for temporary staff impacted by the legislation, but because permanent staff work alongside these folks and are impacted by the way that we operationalize our bill, we are also open to participation from permanent staff. Essentially, what we'd be asking is for you all to share the link or the QR code. People would then register to receive information about our Rule Advisory Committee process when we're going to have it, and then they would be able to actively participate. And that is happening later on in August. I know that was a lot of information coming at you rather fast, and it was really high level. So I'm going to go ahead and open the floor for questions if that's okay.
Okay, committee members, any questions for the Rules Advisory Committee? Okay, so Joe, anything else we need? I'm not hearing anything from the committee.
Nothing else from me.
Okay, well, thank you for coming down, and we'll put this out.
I have a quick question.
Oh, yeah.
Joe, thank you so much for coming here and being here. I'm curious if there are particular areas of the state that you'd want representation in, if there's, any additional information you could share.
Yeah, that's a great question, Neela. I mean, because our workforce representation was so lacking in 2024, essentially we're looking for any workforce members. As we think about operationalizing a program that works towards our 2030 goals, I think it's important that we engage folks from historically and contemporarily marginalized populations. Rural communities and frontier communities are uniquely impacted by this legislation, as they often need a couple extra dollars to recruit and retain folks to their locations that may be less desirable to some professionals. So we're open to all participation, but I hope that in doing so, we're able to create diverse representation statewide, and we'll continue to work towards that if we don't have that this year.
Great, thanks.
Hey, I do have one question. So when you want people from the workforce, you were saying you want some of the temporary workforce who's impacted by this. And so you're okay if they're not residents of Oregon?
Yes, that is correct.
Okay.
Temporary workers that would, yeah, that's fine.
Okay.
Okay. And Joe, is there compensation around participation in the RAC?
Unfortunately, there's not compensation available for our Rural Advisory Committee processes. They're more of like a public opportunity for folks to provide input in our rules and functions, much less like a committee where we're able to offer that compensation to folks.
Okay, thank you. Okay.
But Ian, you're speaking my language talking about compensation for folks' time. So I appreciate the question. I hear you.
Yeah, well, I mean, it becomes a part of that whole equity conversation. Some people just can't afford to participate.
Yeah, 100%. I completely agree. You're speaking my language there, and we'll continue to try to leverage things internally at the agency level to make changes towards committee compensation and things like that. But I think we're probably a bit of ways away from that with the RACs.
Okay. Thank you. All right. So any further questions? Joe, thank you very much for coming and giving us information on your program. And let's see, next slide. Next slide. Folks with, yeah, okay, there we go. Okay. So we're moving along at a good clip. So, Bill, are you ready to present on the Partnership State Loan Repayment Program?
I am, Ian. Thank you very much. Hello, everyone. My name is Bill Funder. I use he, him pronouns, and I am the Incentives Program Manager over at the Oregon Office of Rural Health. And today I'm going to be giving an overview of the Oregon State Partnership Loan Repayment Program, also known as SLRP. Before we get into that, though, a little bit about the State Office of Rural Health. It was created back in 1979 by the Oregon Legislature. During the early to mid 80s, we had our own office building. And then there were some budget crunches in the 80s, and a number of state offices got rolled up into OHSU's administrative umbrella. And that's where we've stayed. So while I have an @OHSU email address, and you'll see some OHSU branding on these slides because we are using their resources, we are the State Office of Rural Health and not OHSU's Office of Rural Health. Next slide, please. So the Oregon State Partnership Loan Repayment Program is a loan repayment program geared towards primary care providers working at health professional shortage areas in an outpatient setting. SLRP is funded by the Health Resources and Service Administration through a grant, and that grant issues money directly to the Oregon Office of Rural Health, and we review applications, we review sites for participation, and the contracts are held over at the Oregon Office of Rural Health, and we also issue the payments for providers out of that grant. The SLRP grant requires that federal funds be matched by non-federal funds for this grant. Providers who apply and are awarded, if you are a full-time provider, which is defined as providing at least 32 hours per week of direct patient care and working 40 hours per week, if you apply as a full-time provider and are awarded, you enter into a minimum of an initial 2-year service obligation. Those who are part-time providers, meaning you provide 16 hours per week of direct patient care and work at least 20 hours per week, you would enter into an initial 4-year service obligation. Providers can come back for up to 1 year, 2 1-year continuations. So no matter if you are full-time or part-time, once you've completed your initial 2 or 4-year service obligation, you can come back to the program for 2 1-year extensions. HRSA typically issues $300,000 per grant year for this grant, which is a 4-year grant cycle. And it requires, again, matching funds. So you're looking at $600,000 in award funds per grant year. Next slide, please. So here is the eligible provider list for SLRP. I'm not going to go through each one, but the common thread here is they are all primary care, outpatient ambulatory care. And they are all master's level and above providers. Next slide, please. So sites that may qualify for SLRP. These are a lot of ands here. There are a lot of musts. A site, all of this is set by the Health Resources and Service Administration, both the eligible provider list as well as the eligible practice site list. It is very rigid, and sites have to be a nonprofit. They must be located in a health professional shortage area, and employ providers who are relevant to that HPSA. For instance, if you are a dental office, your site must be located in a dental HPSA. It cannot use a primary care HPSA to satisfy the requirement. You must be providing that ambulatory outpatient primary care. You can also be providing, again, dental or behavioral health that is considered components of primary care. And you must be providing free or reduced fees to folks at or below 200% of the federal poverty level. And you cannot do asset testing as a way to gauge someone's entry into that sliding fee scale. You have to accept Medicaid and or Medicare and have a site application on file with my office that says you are qualified for SLRP that is no more than 1 year old. Those are the major site qualifications for SLRP. It does not cover all of them. If I were to cover all of them, it would be a whole 30-minute presentation. The federal government in their infinite wisdom has put all kinds of restrictions on sites and providers. You can view them all if you go to our website at the Oregon Office of Rural Health and click on our loan repayment programs. Next slide, please. So provider awards to this program. So if you're a primary care provider providing outpatient care, you're working at an approved practice site and you want to apply for the program, cool. If you're awarded, that's double cool. And full-time providers. So again, those working at least 40 hours per week and 32 hours per week of direct patient care, you could receive up to 50% of your qualifying educational debt, up to a maximum of $25,000 per obligation year. And again, if you're full-time, you're on the hook for a 2-year service obligation, which means a full-time provider for an initial 2-year service obligation could get a possibility of $50,000 in loan repayment funds. Part-time providers, you get 25% of your qualifying educational debt, and that is over 4 years. So you do end up with more possible funding years. So you have access to the money. It's just over a longer period of time, and you are eligible for up to $12,500 per obligation year for that 4-year service obligation. Once either a full-time provider or part-time provider, once they complete their initial obligations, they can come back for those 1-year continuations, and they can receive up to 60% of their qualifying educational debt, up to remaining educational debt at a maximum of $25,000 per obligation year. And if you come back, it's the same thing. So basically, through all of the years, part-time providers, it's a total of 6 years of obligation, and the maximum you could potentially get out of this program is $100,000. And for full-time providers, it is a maximum 4-year service obligation in exchange for that $100,000 maximum. Next slide, please. So a little overview of SLRP. SLRP began in 2009. It's a very long-running program. And from 2009 to 2021, SLRP matching funds were provided by providers' practice sites. So if you're an awardee at a practice site and you are eligible, that practice site needed to have the investment in the program to have their provider awarded. It's never been the best system, but it's the system that Oregon has used again since 2009. And then COVID happened. ARPA money was infused into the SLRP program, and for the past 4 years, SLRP has not required matching funds. There's a little bit of an asterisk in there. When the old grant that required matching funds was winding down, we had 1 year of funding available. That's $300,000 in federal funds. The Healthcare Provider Incentive Program did an infusion of $300,000 in program money to match that federal $300,000 to make $600,000 in awards for that year. And that allowed us to not rely on site match as we were transitioning into the new iteration of the grant. And again, since 2021, we have not relied on practice site matching dollars. Starting September 1st of this year, HRSA will again require matching funds from the states that participate. And without matching funds from the state of Oregon, the program will once again rely on practice site matching, which for various reasons, as you can imagine, is not ideal. ORH, my office, the Office of Rural Health, may request that the Healthcare Provider Incentive Program provide funds to match the $300,000 per year required federal match. Now, of course, that would require approval from both this committee and the Oregon Health Policy Board. So this meeting is to bring you up to speed on SLRP and get you thinking about it before the ask is made in future meetings. So some challenges around SLRP. It's $300,000 in federal money. and $300,000 in site or state money. And it does a lot of good. We have a number of providers who would have left their practice site if they had not received those funds. So it is a great retention tool. And some practice sites also use it for recruiting, but it does have challenges. SLRP has rigid requirements for both providers and sites. Like I said, the provider list for eligible providers has not been updated in many years. I've been at this for about a decade, and in that decade, they only added one provider type, and that was certified drug and alcohol counselors 3, which requires a master's degree. They also have not updated what it means to have qualifying debt. Their debt is master's level and above, and their definition of qualifying debt is master's level and above. It does not take interest into account, so we have to deduct interest accrued on those loans since the beginning when they took those loans out for their medical education. So that's a decent chunk of change that is not being calculated in as qualifying debt. Also, the award amounts have been the same basically since 2009, when we all know that the cost of healthcare education has steadily risen. And the lifetime maximum that a provider can receive out of this program is $100,000, which is considerably lower than some of the other state-sponsored loan repayment programs. It is, the healthcare provider incentive loan repayment, which is a state-sponsored program. That's a maximum of $150,000 in exchange for a 3-year service obligation. So this can take a provider up to 4 years to receive just $100,000. It has limited portability around the state. So if a provider is awarded at a SLRP-approved practice site, they must continue to work at a SLRP-approved practice site for the length of their service obligation. And with a limited pool of practice sites, it's a limited amount of possibilities where a provider under obligation could possibly go if they wish to or needed to switch practice sites. SLRP has a repayment clause that mirrors that of the National Health Service Corps. So if you're familiar with the National Health Service Corps, it's a pretty strict clawback clause if you were to break your obligation. It is one of the stipulations is $7,500 per month for every month unserved. And those are things that HRSA, again, requires of the program and contracts. There's also uncertainty with federal funding and programs, period. This time of year, we would have expected the SLRP Notice of Funding Opportunity, also known as a NOFO, to come out in February, where we would have applied to the program in March and had it sewn up in April or May. It is now approaching mid-July and the NOFO has not been issued. We've had a lot of signaling from HRSA that the NOFO will be issued soon, and the grant application, once the NOFO is issued, we anticipate that we'll have a very tight turnaround time to get that submitted. We're going to have weeks as opposed to normally we'd have months. So as is kind of everything in the federal world, it's a little strange right now. And but we do anticipate that it will be funded, and it will be funded at the level of $300,000 per grant year for a 4-year grant cycle. But we won't know 100% until that NOFO is issued. And again, I'm kind of thinking that it'll likely be before the end of July when we see that NOFO released. Next slide, please. So there we go. No more slides. It is, as the slide says, it's time for a break. But before a break, does anyone have any questions?
I actually had a question. Thank you, Bill. My name is Laura. I'm a med student at OHSU. I just had a question about if you had the breakdown per year of the professions that take advantage of this across the state.
Sure, I do not have that on hand. I can tell you that the largest the largest participant pool for providers here are MDs, PAs, and DMDs, and usually some like LCSWs. Some of the other provider types we don't see as much. We have yet to have a drug and alcohol counselor 3 apply to the program. So there's definitely some provider types that we're not reaching as much as some others. And I think that we can pull some data together if that would be useful, but it'll take just a little bit of time.
Perfect. Thank you.
Okay. Any further questions?
I have a question, Ian.
All
Thank you for all that information. I'm a dentist, and I went the NHSC route, but love loan repayment. And I'm curious, since we anticipate like the site matching needing to come back, maybe you said this, but maybe not directly. Do we have information of like how many sites opted into the program once the matching wasn't required, and so how many we might see drop now that that's coming back?
Yeah, I really appreciate that. Yeah, so prior, and the numbers, I'm going to be pulling it a little bit up by memory here. So these aren't exact, but I do report on SLRT pretty regularly, both to HRSA and various other places. So through my little Bill memory bank here, prior to not requiring SLRT funds, we were sitting somewhere just north of 200-ish practice sites in the state. But then once we made the big announcement that, hey, this does not require site match anymore, we had all kinds of folks who wanted to come out and play. And so we were up well over 400. So we saw a significant increase in the number of practice sites that wanted to participate. And another thing was that because the site requirements match so heavily that of NHSC, what we found happening was actually something pretty cool. Sites that wanted to participate in that program were coming to us asking, do you have sliding fee scale samples that we can use? And luckily HRSA does provide those. So we're able to pull those down, provide them. So we did have some practice sites who didn't have a sliding fee scale that now have a sliding fee scale in Oregon just by the virtue of wanting to participate in that program. And you're absolutely right. Once, if practice site match is once again required, we could definitely see some of those practice sites fall off the roll.
Thanks.
Thank you.
Yeah.
Okay. Committee members, any other questions for Bill?
Oh, Bill, sorry. I had one more question. This is
Yeah.
Laura again. So I know that you mentioned that the amount that an individual is allotted is like hasn't changed since like 2009, and this is like probably not the best like time to bring this up given like what we're hearing every day in the news. But is there any thought, or has there been thought to like increasing that amount, or in particularly maybe like making it like a percentage like allotment per profession? Because I'm just thinking about like the 25,000 per year, like that's like just a little bit over like per term for an out-of-state student at OHSU.
Oh, absolutely. I could not agree with you more. If it was up to us, and HRSA asks regularly for our input, and we provide that input, and it's usually around, we need different provider types, we need an increase in lifetime maximum, we need an increase in the number, the dollar amount per grant year or per obligation year that a provider is participating in. Now, we haven't seen the NOFO yet, so I cannot say whether or not they intend to increase level, hopefully not decrease. That would be really wild. But until that NOFO comes out, I can't say 100% sure what it's going to look like. I wish in a normal world, I'd have more info for you, but it's not a normal world. So yeah, while we continue on the state level in many states during webinars where HRSA is giving TA, technical assistance, that is one of the common things that comes up. We need more money for this. But you're absolutely right. This is a weird time to be asking for more money when it doesn't seem to be out there all of a sudden. So yeah, I don't see that happening likely with this iteration of the grant. Perhaps future will continue to advocate for it. Thank you.
Okay, Jill, I see your hand up.
I just wanted to provide a little bit of little bit more information too, and just kind of reiterate. So in the August meeting, we're really hoping to have a little bit more conversation about how the healthcare provider incentive program, which is within OHA, where I'm kind of the lead, to kind of help outline some funding for that match. So we're going to be, as Bill mentioned, we believe that the SLRP process can extend the life of our current state loan repayment or our healthcare incentive loan repayment. We support the process as well. We review kind of the applications and things like that with the Office of Rural Health. So we're working together, I think, in alignment, and we really are in support of the SLRP matching fund so that we can open this up to other organizations that are, we don't have to require matching funds from other clinic or other organizations across the state. So just wanted to put another kind of emphasis on this is kind of a precursor to the budget conversation that we're going to be having in August, where are going to be having a line item request for that $300,000 match that comes from our budget for this next biennium. Thank you.
Okay. Thank you. Elena.
I just want no more question, just more of a reiteration and a sort of firsthand perspective that you already said this, that it's such an important tool for recruitment and retention. But just to underline that, we've interviewed 5 or 6 dentist candidates in the last few months for positions in our clinic, and every single one of them have cited either national or state loan repayment as a reason that they're interested in working in an FQHC setting. And so I think just to underline for the whole committee the importance of maintaining these programs for access to care and staffing, especially in more rural or frontier or underserved communities. So thank you for the work you're doing on this. It's super, super important.
Thank you.
All right. Thank you. Megan.
Yeah, do you have data on site retention?
You know, that is, we do some surveying, and we can definitely pull that. We can pull some data together and get it to you before the next meeting.
Bill, I was also going to put in the chat. So because with the previous state match that we supported back in 2023, we do include the SLRP. We do include data on the SLRP awardees that came from that $300,000 match in our evaluation, which was just published last month. So I'm going to put that in the chat for everyone if they want to review. It's not the full awardees, but it is, because we provided that match, we're required to include that as part of our evaluation report. So if that gives you a little bit of a snippet of who we were able to support, and kind of, again, stretching those dollars, I think, to be able to provide, retention tools and recruitment tools through this type of loan repayment, either through our healthcare incentive loan repayment or the state loan repayment program. We're really trying to kind of work together and stretch those funds. And I'll share that in the chat real quick as well. So Bill, if that helps.
Thank you. Appreciate that.
Okay.
Okay. Any further questions? Bill, thank you very much for quite a bit of information.
Thank you very much. Appreciate you.
Yeah. Committee members, if you could please stay on the call. We'd like to do the minutes vote before the break so that we can get that done. So the summary. As I said earlier, that was sent out as part of our package of information. Anybody have any comments, questions, or updates they'd like to see to those minutes? Okay, hearing no changes, do we have a proposal?
I'd make a motion to approve.
Okay, we have a motion, second?
I'll second.
Okay. So we'll go through the roll call for the vote. Aaron Hines. Elena Shabowski.
Aye.
Alicia Jackson. Boy Vu.
Aye.
Eric Weiser.
Aye.
Gabriela Carrillo. Gretchen Horton Dunbar.
Aye.
As for myself, aye. Jason Johnson. Judy Geiger.
Aye.
Kelly McKnight. Larissa Mejia Medina. Levi Anderson. Manu Chaudhry.
Aye.
Megan Holland.
Aye.
Molly Reynolds.
Aye.
Rob Ross. Bob Lieberman. Dr. Hemmings.
I have a question. I thought we couldn't vote because we didn't have a quorum.
We got quorum over the.
Oh, okay. Hi, yes.
Stephanie Grayson. Surya Carla Papi. Tessa Christensen.
Aye.
Okay, thank you, everybody. It is now 10:58. Why don't we come back from break at 11:10? It's a little bit longer break. Please turn your camera on when you get back so that we know you're back with us.
We are still recording. I will simply edit out the break after I download the meeting.
Okay, thank you. Okay, if everybody, committee members especially, would turn on your cameras, let us know you're back with us. Hey, Jessica, can we get the next slide, please? Okay. Let's see. Brett, are you ready for you ready?
Yes, indeed I am. Well, good morning, everyone. Yeah, my name is Brett Golden. I use he, him pronouns. I work under the Behavioral Health Division at OHA, under a special team called the Behavioral Health Workforce Incentives Team. Our team was birthed out of House Bill 2949, where our goal was to take $80 million and inject it into the behavioral health workforce for recruitment and retention efforts. So we did a lot of various things like loan repayment, tuition assistance, scholarships, clinical supervision. And so that's been primarily our task. But one of our other objectives too within our team is to help streamline the workforce pathways into behavioral health. And the QMHA pilot really fits that nicely. And so that's where we're here today to talk about. I help co-manage this pilot program, and I will also pass it over to my other colleague who helps co-manage it with me from MacBo, Christy McKinney. If Christy, you are still on, I'm not sure. I didn't see if you were or not.
I'm here.
Okay. Do you want to?
I will introduce myself. I'm Christy. I'm the Director of Credentialing, Compliance, and Testing over at MacBo. For those of you that don't know who we are, we're the Mental Health and Certification Board of Oregon. We certify all unlicensed mental health and addiction workers and peers in Oregon. And I get to work with Brett on this project, and it's been wonderful.
Yeah, thanks, Christy. Yeah, it's been really great. We just started this pilot program. So without further ado, we'll go through the slides. And Christy, if there's anything that I forget, please feel free to just chime in whenever to clarify anything. But go ahead and go to the next slide, please. Okay. So as we all know, Oregon is currently facing a behavioral health shortage. And one way that we're trying to look at that issue, like I referred to, is accelerating career pathways. The way we think about it on our team is like the superhighway concept, where you can jump on at any point and get off at any point. So through your education and wherever you land, whether it's being a peer or being a certified behavioral health professional or a licensed provider, you can find a way to insert yourself in behavioral health and help out. So we partnered with MacBo. Essentially, what we have for the QMHA certification, it's governed through MacBo, one of the primary credentialing bodies for the Qualified Mental Health Associates certification, kind of like behavioral health technician. They can help with assessments, screenings. They don't always diagnose, but can be very, very vital for a behavioral health organization because they can bill for Medicaid. So as it stands right now under our Oregon administrative rules, there are two pathways to become a QMHAR. One of them being having a 4-year degree in a behavioral health related field. Or the alternative pathway is the non-degree pathway, which is 3 years of relevant experience, education, and training. You also must accumulate over 1,000 hours of relevant work experience to meet the non-degree pathway. So either a 4-year degree or 3 years combination education experience. Next slide, please. Okay. So highlighting just really quickly the 3-year non-degree pathway. These are all the ways you can get to that. I'm highlighting the associate's level pathway because that's what we're doing with this pilot is we are working with associate level programs. So for a student that might have an associate's degree, you got to have the 90 quarter college credits, and that's your associate's degree. But then on top of that, you have to do 1,000 hours of work experience in the field. So that's a half a year. So what's hard with that barrier is that you have these folks that have an associate's degree, but behavioral health organizations don't necessarily want to hire them because they can't use them to bill for Medicaid for services. And so they have to get all these odd end experience hours where where maybe a behavioral health organization might not be interested in hiring them right off the jump because of that that barrier and issue. Next slide, please. Okay. So because of that, from August 2021 to May of 2022, Lane Community College, particularly Lane Community Health Council that helps govern Lane Community College, identified this issue and advocated that one of their associate's degrees was a specialized 2-year program, but it also provided over 648 hours of practicum and real world work experience in behavioral health. So that would only be 352 hours short of the non-degree pathway. And so what Lane Community Health Council was advocating for a long time was saying that their specialized program was on par with the 3-year non-degree pathway. Next slide, please. Okay, so and this work happened before I came on. My colleague at the time, Joe Bergeron, worked with Lane Community Health Council, talked throughout OHA about the QMHA certification, also talked to some community colleges and identified 10 additional community colleges that offered the associate's degree in behavioral health or social service adjacent. And then they also provide a level of practicum, real world experience, internship, work experience to get your associate's degree. So at the time, Joe Bergeron created this report and recommended that we do a pilot program to see if these identified community colleges are on par with the non-degree pathway, and seeing if these individuals have the same work readiness as maybe someone with a bachelor's degree or someone that has 3 years combination education experience. So next slide. Okay. Oh, maybe one more back. Okay, I'm sorry. Go ahead. One more. I thought we skipped one. My bad. Okay. So that's kind of where we're at right now. So starting at the beginning of this year, we launched the QMHA pilot to offer 2 temporary QMHA certification pathways for these specialized associate degree programs. And next slide, and I think the next slide should kind of demonstrate what those pathways are. Okay, here we are. So the first being the specialized 2-year program. So those identified community colleges throughout Oregon that offer the associate's degree and then practicum experience in behavioral health settings. We also have a temporary pathway for specialized QMHA apprenticeships. And so that is for apprenticeships with 3,400 behavioral health work experience hours and 290 related training and instruction hours. So very equivalent to the specialized 2-year traditional pathway in behavioral health for the associate's level. And so that's primarily with United We Heal. We work closely with Andy Freeman over at United We Heal to draft up what the specialized QMHA pathway would be for apprenticeship students. So we just launched it. We worked really closely with the programs to build out a pilot draft. And right now we have students registering. This pilot will span until spring of 2029 with the goal to have these students graduate, get into the behavioral health field, work at behavioral health organizations, and then we are collecting data on the back end and Our goal is to compare that to the QMHA workers already in the field to determine if there's any differences in work readiness and competencies. So spring 2029 graduation is the end date. Community colleges are instructed to work with their students to, of course, get them graduated by that time, but they can also go back and look for maybe students that are halfway through completing their degree and they decided not to do it, and kind of announce this opportunity broadly for anyone who might be interested in this specific certification. So the idea is you finish your associate's degree or your specialized QMHA apprenticeship program, and you get that QMHA certification after that, where you are ready to work in the field and you have that certification, which is really important for behavioral health organizations and providers. Next slide, please. This is just a visual of the current Oregon administrative rules for the QMHA certification. So like I've mentioned, you have the 4-year degree pathway, the 3-year non-degree pathway, 3-year education experience non-degree pathway, and then we have the new temporary pathways through the pilot, which is the 2-year associate's degree pathway with practicum experience, and then the 2-year apprenticeship pathway, which focuses more on experience, but with classroom instruction as well. Next slide, please. Okay. I think one more back for desired outcomes. Forward one more. Thought we might have skipped one. No, keep going forward. Sorry, we're going backwards now. I thought that we might have skipped one again, so I apologize if that's just my mind playing tricks on me. Yeah, we're still going backwards if we can. Yeah. Okay. Yeah, right here. That's good. Let's stick with this one. So here are the desired outcomes of the pilot. One being practical experience. We want to make sure that these students have practical experience in the behavioral health field and they are ready to work as a QMHA. So when we're gathering this data over the next 4 years, that's our goal. And what we're going to do is compare it with the QMHAs already working in the field to see if their competencies are any different. If they're not, our goal is to recommend to revise the Oregon administrative rules to allow for these pathways. So essentially removing some barriers into entry of the behavioral health field. So to increase accessibility and also improve workforce development, get more folks in the door in behavioral health at the community college level and also at our apprenticeship level. Next slide, please. Okay. So right now, these are the current participating programs in the QMHA pilot. We also are working with Lynn Benton. I don't believe they're listed here, but we have just added them. And then we're also working with Treasure Valley out in Ontario to be a part of the pilot as well. You see United We Heal there. One program to point out is University of Oregon Balmer Institute. That is a bachelor's degree program in children's behavioral health. However, they're interested in the pilot in the way of certifying their students halfway through their bachelor's program. So then they can get that work experience as they're going through completing their bachelor's degree. So halfway through, about 2 years equivalent is what we'll be working with U of O to certify these individuals as QMHAs. Similarly, I just talked with an individual over at Oregon State University, and they're hoping to do a 5-year accelerated MSW program. And we're in talks once they have that up and running. It's going to be an all online degree program to certify them as well halfway through their education as QMHA individuals. Next slide, please. Okay, so here's some data that we're collecting. Essentially, the community colleges are having their students who are interested in participating in the pilot that are under these qualified degree programs register with MACBO. And so essentially the students just get a link to register. They fill out all this information. And so we already have a bunch of information about our participating students. And so a lot of that being like contact information, obviously, but like really important information like REAL-D and SOGI data, age, financial aid status, preferred learning, background in behavioral health, just to get a little bit more background on the individuals participating in the pilot. Next slide, please. Okay, and I think that's it. I'll open it up for any questions. And Christy, is there anything that I missed or anything to add regarding the QMHA pilot?
No, I think you covered everything. I will say, I believe we have 3 people that just graduated in June that got their transcripts in and are now QMHARs. So we're moving along. I was really excited to get the first ones. Transcripts are kind of just trickling in right now, so we'll see more in the next month or so.
Yeah, it's fast how quickly it's all happening. It's awesome.
It's crazy.
It is, and just piggybacking off of that too, we have right now about 122 students who have already enrolled. We're hoping those numbers will, of course, increase as we move forward. We're going through summer break right now, but we're hoping by fall term we'll get more students enrolled in these specialized programs. So yeah, we're really excited to see what comes of all this, but
absolutely.
All right. Thank you very much.
I see Dr. Hemmings has a hand up.
I saw that too. Yeah, thank you.
Hi, hello. Thank you for that presentation. A question I have, I noticed that you mentioned that there's going to be some analysis done to compare the students who go through this accelerated process program versus students who don't or who have the full required amount of hours and credentials. What metrics are you using? Do you have that information that you will use to actually do that comparison, and over what period of time? Like the first year out versus first year for someone else who came in to the field with, you know, the regular requirements versus year 2. How are you planning to conduct that analysis? What metrics are you using?
I can answer part of that, and then Brett probably has more. So the first thing that we're using is everyone who applies for a QMHAR has an assessment. It's a pretty basic assessment, but the Oregon Administrative Rules state certain competencies that you have to meet in order to provide these services under a QMHA or QMHP. So that's the first thing we're going to compare is when a bachelor's degree with no practicum student has that assessment, as opposed to a community college student that has a practicum, where are those assessments at when they first start in the field? And we have all that information at MACBO in our database. We want to see where's that jumping off point. And then after 1,000 hours or 6 months in the field, there's a more comprehensive assessment. And we want to compare those and just see in what categories, maybe the bachelor's degree knows terminology better or basic counseling skills, whatever we're looking at as far as those competencies go. And then we're going to do things at MACBO like, did someone renew their certification at 2 years? If they didn't, why? Did they leave the field? We need to find those reasons. Was it because they didn't feel prepared? Or was it lack of support from a supervisor? All those different things. And ethics. That's what we really look at because we do lots of ethics cases. So we'll look and see, are ethics comparable there? Are new people with only, maybe 2 years of a degree getting more ethics complaints? And where do those ethics complaints lie? If they're sleeping with your clients, that's a big problem. But if it's If it's maybe a confidentiality issue, then we can make sure that the schools focus more on those areas as opposed to just scrapping the whole idea because, of this one area. So it's going to help us with curriculum. We're also going to look at all of the other things. We're going to look at rural areas. We're going to look at our lesser served communities, all that stuff. But I think the assessments and those are going to give us a really good view of what's happening and how people are excelling. Brett,
So it sounds like you're looking at knowledge base versus actual practical, how they're actually functioning in the field.
Well, the assessment is actually done by their clinical supervisor.
Okay.
So it is going to be based on, we actually give them, in the first assessment, they can assess based on education. That second assessment is on skill. That's, are they ready to be fully certified and work in this field? The first one is kind of that jumping off point where maybe they need a little improvement in this area, in documentation. And so, yeah, that second assessment is going to be definitely skills based. And we'll know who, it's kind of a catch-22. We need to see how the education plays out because that's what's qualifying them, but we also need to see how they are doing skills-wise in the field. It's going to be telling in a lot of ways. We might find that we've got supervision problems. We might find that the education wasn't the big thing, that more experience prior to being certified is important. So we're just going to go with the flow and see kind of how it plays out, especially this first year, and we're going to track for 4 years.
Just remind me again, the supervision occurs within the entity, the organization. It's not external, right?
It can be, but in mental health, it rarely is. In SUD and substance use, it more often is because we lack CADC 2s and 3s in our state. But in mental health, it's almost always in-house, 2 hours per month, and those supervisors are on site, observing and working with the QMHAs and QMHPs.
Okay, thank you.
Oh boy, there's lots.
Okay, Judy.
Yeah, thank you. I just have a couple of questions. I've looked at nurses practicing at the same level with either an associate degree or a bachelor's degree. So, there are pros and cons to it, as you probably have all seen as you develop this program. Are the students going to be encouraged to go back and get a higher level of education? And if so, is there a seamless pathway for them to do more education in the future?
There's the question I wanted. So what we're looking at is, we've all heard the career ladder is the big push. Since I started at MACBO 8 years ago, there's a big gap between the QMHA, which you can qualify for with no education. You can qualify with just 6,000 hours of experience. But that next step is a QMHP, which requires a master's degree. This is where we see people leaving the field because there's no ladder, there's no upward mobility there. So with this, we created, when we took the certifications on, we created the QMHA 2 for this reason. We want that to be the stepping stone. You get an associate's degree, you start as the QMHA. Then we'll have pathways for that QMHA 2. Maybe it's more experience and more apprenticeship. I'm looking at that. If it were my perfect world, the QMHA 2 would be bachelor's level. You get that, then you just got that 1 more year or 2 more years, and you've got that master's degree. So we want to really pump up our community mental health, our state approved agencies, because we have a hard time keeping QMHPs that move on to licensure, which I understand completely. So yeah, that's where I came into this, that's really where I want to see this moving. And we just want to get more people access that maybe, not everyone's going to college these days. It's expensive. Community college when I started was like $40 a credit. So it's not that anymore. It's a lot of money. So we want different pathways that people can advance in their careers. And hopefully, we can see that change. But that's my goal. That might not be everyone's.
Okay. Let's see. Dr. Hemmings, is this the same question or a new question?
No, this was a new question, but I see, Dr. Chaudhry, you had your hand up and I already asked one question, so I'll wait for you to go.
Excellent. Can you guys hear me okay?
Yeah.
Okay, great. Perfect. Thank you, Dr. Hemmings. Just as way of background, my background is trained as a dentist, and each of our kind of healthcare professional fields that we have are ripe for disruption of diversity, right? The more we can have, the more people in our village of care, then more likely access improves, health of the population improves, and stuff like that. And in over the last few years, I've come to realize that not only do we need diversity within each of our health professional components, but then we also need to increase interconnectedness and kind of between our different health professions. And so as I was reviewing the presentation material, I felt as though that it would be a good idea for some level of exposure to other healthcare professionals. We know the vicious cycle that exists between, someone who has no teeth or are missing teeth and how that impacts their mental state and emotional state and self-esteem, and then that vice versa component. Someone who has behavioral health concerns, and then how it impacts their ability to manage and take care of the teeth and prevent them from getting dental pain. So while on the superficial cursory level, I was unable to see that there was that level of exposure, but I would greatly appreciate if, as new types of healthcare providers come on board, whether in pilots or not in pilots, we really seek to increase the level of interconnectedness that we have between each other to then create a more holistic health plan for our people. Thank you.
I love that so much. For our peers, we do a little bit of it because we do the oral health training that's required for them, but it's such a big deal. As somebody who's in recovery myself for 18 years, I know the struggles. We really need that. It's always been SUD and mental health kind of not wanting to coexist real good, and then we do, and then we don't. But we forget that there's dentistry, there's medical, there's all these other fields that we all impact each other. So I love that you said that. Thank you.
Mhm. Okay, Dr. Hemmings, we have a couple of more minutes and then we've
Yes,
got United
really,
Way.
really quickly, just, my 30-something years of doing clinical supervision for MSWs and some BSWs. One of the things that I think that, needs to be advocated for as part of this program is you mentioned that, people moving on to get higher degrees. Part of the issue here is, organizations oftentimes are very comfortable with having someone who is just, at the lower level and is able to perform. They can get reimbursed for those services. And oftentimes, what I find that happens is when someone goes back to school and they get, for example, their master's, the organization does not compensate them for having that master's degree. So what happens? They leave, right? They leave that organization, or they stay and they're very unhappy because they feel that, they've gotten this master's degree, but there is no difference in terms of their compensation. But yet that degree that they've gotten is helping that organization, right? Because their skill level is different. And I see that a lot that happens in the Portland area, Beaverton area, where I've supervised MSWs who work at CBOs who are QMH. And when I say, so what's your plan? Are you going to stay at the organization? They say no, because they're not acknowledging that I have now moved on and gotten this degree. So I think that needs to be considered too. Thank you.
It's a really great perspective. So often we just look at reimbursement rates as the only factor, and it's really not. It's what you just said. Thank you for pointing that out.
Yeah, and one thing to add to that too is, on our team, we're also incented. So what we're trying to do too, and that's also a part that we're trying to connect with this, is driving organizations to these students and getting those students to where they are needed, but also awarding those organizations that have those workforce shortages with tuition assistance, scholarship funding, so that an individual at the QMHA level, if they do want to pursue their master's, could get assistance with tuition assistance or scholarships or stipends in that way. And so recently, just at this end of this legislation session, we'll be working with House Bill 2024, which is $5 million for incentives for qualifying behavioral health organizations. It's a very small amount compared to what we did with the 80 million before. But what we're hoping is that we can continue that and show models of success where we insert these opportunities at these behavioral health organizations where you do have these individuals that might be entering in the field, but they stay there because of the incentives that their organization is offering.
Yep.
Okay. Well, thank you both very much. And we are going to need to move forward to the folks with United We Heal, Haley Coop and Dave Hayden.
Hi, I'm Haley Coop. I am our Behavioral Health Career Pathway Supervisor with United We Heal. And then I will pass over to Maeve to introduce herself, and then I'll start our presentation.
Hi everyone, my name is Maeve Hayden, she, they pronouns, and I manage the QMHA program for United We Heal.
And I use she, her pronouns. So we're United We Heal. Really excited. I feel like the conversation, all the questions and discussion really teed this up great for us to talk about our organization, our apprenticeship pathways. We're definitely going to focus on the QMHA pilot since that's why we're here. But hopefully we'll touch on some of the other questions, that career ladder and all the other programs that we have that we think really help build our workforce. So United We Heal was formed in 2021, really as a solution to the behavioral health crisis that we all are super aware is happening in the state. Our organization focuses specifically on behavioral health workforce development. We do have a medical assisting apprenticeship program as well, but most of our programs are in behavioral health. And with the apprenticeship model, we have seen that these programs actively promote diversity, equity, and inclusion in the workplace. We are a labor management training trust, and we partner with Oregon AFSCME Council 75, which is a labor union in Oregon that represents a lot of the behavioral health nonprofit organizations. And Labor Management Training Trust, that just means that we have both representatives from labor, so from AFSCME, representing the worker voice, and then also from management. So we have management representatives on our Joint Apprenticeship Training Committee and our board that help oversee just the way our training trust operates and decisions made in our apprenticeship programs so that everybody has a voice in the process. Next slide, please. Just a little bit about our funding sources. So we are fully grant funded and funded through a combination of state and federal grants. We have thankfully not been impacted by any federal issues happening yet. We have been a recipient of Future Ready Oregon funding in the past. We are a How To Round 6 recipient, and we've received previous How To funding. So just talking about our different funding sources, we have several grants that we're always working on. Next slide, please. Okay, so our solution, and these slides were sent out. So if you on own time too, want to go in and zoom in on everything, that might be helpful as well. But this is just a quick snapshot of our pathways and how they differ from the traditional pathway. So the traditional pathway for these certifications, specifically as we're looking at the Qualified Mental Health Associate and the Certified Alcohol and Drug Counselor certification, they require multiple years of post-secondary education, which means that people are entering the field with a significant amount of debt, which, as I'm sure we're aware, the current wages for positions in the field, in those QMHA and CADC roles don't really justify the amount of debt that people end up having to take on and the time away from the workforce that it requires to go back to school full time for a lot of people. So our solution is apprenticeship pathways. So this is something that the trades have been doing for a really long time in construction, plumbing, etc. These are tried and true pathways that we have used the model for this non-traditional apprenticeship model to be able to help advance people's career in a quicker, more equitable way. We provide free education in our programs, and people are in paid positions working and getting the value of that work experience in an earn while you learn model. Just to highlight from this graphic here, one of that big arrow going both directions that you can see is that to get from just starting out in the field to QMHP, our pathway is about 2 years shorter than the traditional pathway, and it's free for apprentices. And we do see this as like Christy and Brett were saying, this kind of place where people can come in at any point in time and be able to access our programs. Next slide, please. So benefits of an apprenticeship. So like I said, all the training costs are completely free. So this is free to apprentices. Apprentices don't pay for the educational component. They're working with us to get that education piece. So some of our classes are provided through contracted schools that we work with. And then we do have some classes in-house that we provide. But they are all free. All materials, all instruction, all of that is free to apprentices. The training agent, the agencies that we work with, those partners also don't have to pay to participate in these programs. They're paying for the staff, the wages, but otherwise it is not something that they contribute to. We're grant funded, and that's how we support this. The full coordination and support. So each of our programs has a program manager. Like Maeve, we have a Maeve for every program. And they see the apprentices from beginning to graduation. So that's somebody to help apprentices through the credentialing process, through the tracking of their hours and education, which really helps people kind of demystify that process. And then employee retention. So this also just helps with keeping people in the field. So people do not have to leave the field to go back to school full time and get the education and then come back and hopefully work in the same places that they were in. This just allows them to stay in the field. So a big pool of employees that we work with are incumbent workers that are in entry-level behavioral health roles that maybe have some experience or did some college classes previously, but haven't had a way to continue their education and advance their career without a pathway like this. So this really allows for, again, diversifying of the workforce and providing opportunity to people that otherwise didn't have it. I'm going to have Maeve talk about our QMHA program specifically. I do want to mention too, just as we're talking about QMHA, like that previous slide showed the career ladder. We have our certified alcohol and drug counseling apprenticeship program. We also have a pre-apprenticeship program that works with high schoolers that prepares them, gives them some coursework in psychology, behavioral health type classes, and some hands-on training that we provide that prepares them for entry into our apprenticeship program once they complete high school and graduate. After the CADC and QMHA, we have a credit for prior learning program that we are currently partnering with State University of New York, SUNY Empire. They have assessed the CADC and QMHA credentials in our apprenticeship program as a whole and are providing credit for prior learning, or CPL, for those credentials so that people have an opportunity for an expedited, quicker pathway to get a bachelor's degree. And so we have currently 5 people in that pathway right now, and those are paid for by United We Heal. And then this fall, really excited to start a QMHP apprenticeship program. And we have 2 education providers for that. So we have Western Oregon University and have a couple apprentices that will be going into that program. And then also working with Eastern New Mexico University for their graduate counseling program. So really excited that for that QMHP pathway as well, that people will have the opportunity to stay in their workplaces, get paid while going to school full time, and having a free master's degree, which is pretty amazing. Next slide, just looking at our training agent partners. If we could have that move forward one. Thank you. So we do have a lot in the Portland metro area. You'll see we have Cascadia, Outside In, Multnomah County, Central City Concern, Sunstone Way, Janus Youth. But we do have some more rural partners with Clatsop Behavioral Health. We had Mid-Columbia Center for Living out in the Dalles Hood River area. ORTC has a lot of locations around the state. So we operate statewide and provide these opportunities to any training agent partner that signs on with us. These are our current partners, though. I'm going to pass it over to Maeve to talk about our pilot and our QMHA program specifically.
Thanks, Haley. Next slide, please. So the QMHA apprenticeship, Christy mentioned earlier that you can qualify for QMHA with just 6,000 work hours. So right now we primarily enroll folks who have between 1.3 and 2.5 years of experience. But with the implementation of the pilot, which I'll talk about in a moment, we're going to be able to expand that enrollment, which I'm really excited about. So any direct service role working in behavioral health is considered apprenticeable for QMHA. And apprentices for QMHA work their regular job duties, get mentorship, and I think that mentorship is a really valuable component of the apprenticeship model. They're able to work directly with someone who has already achieved a QMHA credential or higher and kind of get that career guidance, professional development from them while they're in the program. And then while they're working and getting that kind of mentorship component, they do take classes that are asynchronous through the U.S. Career Institute. You can see them outlined there. It's kind of a sort of just like primer to entry-level behavioral health with your intro to psychology, social works, and abnormal psychology, health and wellness, and an ethics class. Next slide, please. So with the expansion of the QMHA pilot, these are just a couple of things that we're excited about. So as Brett mentioned earlier, it's going to be an expanded OJT and an expanded RTI expectation, which is going to allow us to enroll folks essentially sooner in their healthcare career. So we're going to be able to offer a couple of additional classes to folks, which we're excited about. It'll just give them that much more education while they're in our program. We also have a number of folks that are currently enrolled Field, which since the pilot does allow us to kind of do some retroactive examination, as Brett also mentioned earlier, we have some folks who are in the program and are really eager to get their credential and start working. They've finished all of their classes and they're kind of just waiting out the clock on getting the required work hours. So being able to offer those super eager folks some extra classes to kind of speed up their credential based on their own interest is something we're really excited about. We're also excited about the fact that we'll be able to enroll folks earlier in their behavioral health career. So I think, to me, the biggest value of the QMHA apprenticeship is the ability to give all these introductory level classes to folks who maybe just got an entry level job as a peer, don't have a huge educational background, but are really interested in advancing in the field. So being able to get people even sooner and not necessarily having to wait for them to have a certain minimum amount of time so that they can finish the program and get credentialed in time based on our agreement with BOLI, I think is really exciting. So we're going to be able to expand the apprenticeship opportunity to even more people, and specifically to even more folks who are earlier on in their career than we're currently able to take on. Next slide, please. So just a little bit about apprentice resources, because we think they are super key to our program success. So as Haley mentioned, every apprentice gets a program manager. So you meet with program managers once a month. They kind of monitor your progress on work and school, and do whatever it takes essentially to support the apprentice. We do have supportive services available as well, which I'll talk about a little bit more on the next slide too. But basically, we're able to offer emergency financial aid for apprentices for things like rent, gas, groceries, childcare, etc. And we found that that has been really key to helping a lot of folks ultimately complete the program. And then we do have quarterly study halls as well. We offer these virtually as well as in person, so that folks can kind of meet with each other, network, spend a whole day just kind of knocking out some classwork, meet with the program managers, and sort of, yeah, develop that kind of trade identity and entry-level behavioral health, and create those, yeah, lasting connections in the field. Next slide, please. So a little bit more about apprentice resources. These are the breakdown. We've been able to offer $200,000, almost $200,000 in supportive services thus far, primarily going to rent, transportation, groceries, and study hall incentives. So we have a quote on here from an apprentice talking about the impact of supportive services on him. This apprentice's story was essentially that he'd fallen pretty behind on his classes because he lost housing and had to kind of make an emergency move. He also has a son with a disability, so we were able to ultimately help pay for part of that initial apartment deposit. He was able to stay in the program, was super motivated to pass all of his classes, and wound up finishing on time. And his employment placement, Cascadia, recognized the work that he was doing, and they were able to kind of hold a promotion opportunity for him. So once he got that credential, he was able to access that promotion, had even more access to kind of that ability to provide for his child. And that, yeah, that's just one quote that he wanted us to use. We're thrilled to be able to offer these because we know they make a really big difference for people. Next slide, please. So just quickly touching on our overall outcomes, we've been able to support over 254 healthcare professionals in advancing their careers. Right now, we've got 66 registered apprentices, including 33 QMHAs. We've had 80 graduates across all programs. Average age of our apprentices is 38, and about 73% of them had their highest level of education prior to entering the program was high school or a GED. 90% of our apprentices identify as members of an underserved community, so I have outlined down there how we define that, and you do have access to these slides if you'd like to review that as well. Next slide, please. Just a little bit more on outcomes. So I know these are small charts, so I'll just kind of read them out for you. So 76% of our participants identify as female or non-binary, 58% as BIPOC or Latinx, and 19% as a person with a disability. So we're just kind of raising up these numbers because compared to census workforce population data for the state of Oregon, we do have higher rates of participation than the average workforce for these populations. Next slide, please. That also concludes our presentation. We're happy to take questions if y'all have any.
Okay, committee members, any questions? Megan.
Hi, Megan Holland. How many apprenticeships can you support in your program, and is it competitive in any way for applicants?
Yeah, that's a really great question. So right now for our QMHA and CADC program, we haven't met like a cap of how many people we can support. Basically, when we have a training agent that has somebody in a role where they can get those hours, we're able to enroll those people. As far as the credit for prior learning program, that is obviously a more expensive program, and we had funding for 5 slots. So those slots we used. We hope to expand that program as funding and partnerships allow. With the QMHP, that obviously, again, our most expensive program to do a master's degree, along with our the education component for the QMHP program, there are some wage reimbursements and clinical supervision reimbursement costs to the employers specifically, which makes it just a really big package. So that is a more competitive program. With being a registered apprenticeship, we do have a selection criteria. That's just a requirement of being a BOLI registered apprenticeship program. And so our selection criteria really works to make sure that these opportunities are distributed equitably among applicants so that it's not just agencies picking whoever they want to be part of these programs, that it's really looking at people's experience, people's backgrounds, and assigning points to that criteria as a result of that.
I appreciate that.
Okay. Let me see. I don't see any other hands raised. Haley, Nate, thank you very much, as well as Brett and Christy. We're going to rush through there. I want to thank you all for your presentations today. It's been really great to hear from you and the great work that you're doing. So now I would like to move on to an in-depth look at Oregon's licensed behavioral health workforce. Piper, Andy, Meredith.
Thank you, Chair Strauss. So Piper sends her regrets. She's not able to join us today, so I'll just be kicking off our slides. And I may push through the first few slides relatively quickly because as a committee, we've talked to you a handful of times before, and so hopefully you're familiar a little bit with the program. But to refresh things, we might go to the next slide. I'm Andy Davis. I'm a research analyst with the Oregon Healthcare Workforce Reporting Program. I'm here with Meredith, who's our other research analyst, and she'll introduce herself when we get to her slides as well. And we are managed by Piper Block. And maybe next slide. Our team sits within the research and data unit within health analytics. And we were created in 2009 with the passage of HB 2009, which basically created OHA and this committee too. And our task is to collect data on the licensed healthcare workforce. I make that distinction especially because we just heard a couple of presentations that sort of concentrated on the certified portion of the healthcare workforce. And I just want to make sure that it's clear that this presentation is about licensed professions within that workforce, and we'll talk a little bit more about what professions that means. But it is a little different than what we've just heard. We report to you and the Oregon Health Policy Board. We also work collaboratively with the health licensing boards, the 17 of them, that are within our program. And maybe next slide. So we conduct a survey, either with the licensing board as a sort of delegate of them, we administer the survey, or in the case of Oregon Medical Board, they conduct their own. That survey happens at license renewal. It takes a few minutes, and then we collect that data, and we generally do a big round of processing and analysis of that data starting every January. So a lot of the data that we're talking about today is basically data leading up to January 2024, excuse me, it's 2024 data for that 2024 cycle. We collect it based on licensing renewal cycles. So sometimes it's 1 year, sometimes it's 2. That just depends on what kind of license we're talking about. And we do it usually basically at the end of the licensing renewal process. It's a requirement, so we do get all of the professionals who are renewing every year, so that's nice because we have basically a full sample. And next slide, please. This is just a list of the boards that we initially added in the 2009 when our program was created. None of the behavioral health focus boards are in this group. And then next slide, please. And then we added a new series of boards in 2015. Some revisions to our statute were passed. And so starting in 2016 and 17, depending on, again, that license cycle, we added a new series of boards, which includes the boards that we're talking about today, which are the Board of Licensed Social Workers, and then the Board of Psychology, and the Board of Licensed Professional Counselors and Therapists under the Mental Health Regulatory Agency. All told, this is behavioral health and non-behavioral health. We have over 200,000 surveys in our database at any given time. Some data will roll out as it gets older because we sort of concentrate on what our current workforce is. But as far as current data, we have over 200,000. Next slide. This is just a slide about the contents of our survey. We get some general outlines from statute about collecting demographic data, practice pattern data, and things, and we collect things about the practice location. So we ask them where you work. They give us some data about that. They give us data about what kind of clinical focus they might have, how many hours they work, things like that. And that's the basis of a lot of the reporting that we'll talk about today. Next slide, please. And this is just a rundown of some of the products we create. Again, we've come to you and given reports on our supply report and the diversity of our healthcare workforce. We also contribute to the needs assessment that you all see every 2 years. And we've contributed to some other reports like the post-secondary healthcare education shortage in Oregon through HEC. And Meredith, actually part of her job detail is also we contribute to HRSA's shortage designation management system that helps us sort of locate places in the state that might need some bolstering. Your presentation packet should have links to all of these if you're interested in the reports. And if you have questions about any of this material, we're always happy to answer them. But next slide. And I'm going to hand it over to Meredith.
Thanks, Sandy. Hello, everyone. My name is Meredith Halling. My pronouns are she, her. And I am also a research analyst with the Healthcare Workforce Reporting Program. And I am going to provide an overview of what is in our recently published behavioral health data brief. Next slide, please. So this brief focuses on the 4 occupations that we collect data from with the Healthcare Workforce Reporting Program survey. And these 4 groups make up the majority. So almost 85% of the licensed behavioral health FTE in the state. So that includes clinical social work associates, psychologists, licensed clinical social workers, and counselors and therapists. And that counselor and therapist group includes the licensed professional counselors and the marriage and family therapists. FTE stands for full-time equivalents. And in this data brief, FTE always refers to direct patient care FTE. So one direct patient care FTE is 40 hours per week of direct patient care activities. As Andy kind of showed a couple slides earlier, the survey asks folks how many hours a week they work, and then the percent breakdown of that time between direct patient care, teaching and training, research, and administrative tasks. So based on the information the licensees provide, that's how we calculate direct patient care FTE. And of course, I will mention, the state's behavioral health workforce also includes a lot of non-licensed professionals. So for instance, the registered counselor and marriage and family therapist associates who are registrants of the Oregon Board of Licensed Professional Counselors and Therapists, but they are not required to take the Healthcare Workforce Reporting Program survey. And then there's all the professionals who are certified by MACBO, all professions that are not required to participate in the Healthcare Workforce Reporting Program. And so they are not reflected in this data brief. Next slide, please. So focusing just on these 4 licensed occupations, we see that Oregon's behavioral health workforce grew quite a bit from 2018 to 2024. So this growth is seen in increases in direct patient care FTE, which is what is being shown here on this chart, as well as in the total numbers of professionals who are practicing in the state. And we also see that the master's level professionals, so the counselors and therapists, the licensed clinical social workers, and the social work associates, have larger increases in both FTE and overall numbers practicing compared with the doctoral level psychologists. Next slide, please. So to understand how these providers are distributed across the state, we mapped county level provider to population ratios. So darker shades of blue correspond to higher ratios, which we consider better because it means that there's more provider FTE per person in that county. So looking here at the 2024 data shows that Multnomah County has the highest amount of provider FTE per capita with a 34.3 circled in red and with the little arrow, 34.3 behavioral health professionals for every 10,000 residents in the county. This map is showing provider to population ratios for all 4 occupations combined, but Multnomah also does have the highest concentration for all 4 occupations individually. And I will also note here that the structure of the brief, it's set up in 2 chapters. So the first chapter presents data for these 4 behavioral health occupations combined, and then the second chapter includes all the information, the same kind of analysis, but broken out by individual occupations. So for today, for this overview, kind of for the sake of time, I'm just going to show the combined figures. So for example, just this map instead of all 4 separate maps. But the brief, of course, includes the figures for all the individual occupations. So if questions come to mind, we have that available. Let's go to the next slide, please. In addition to looking at where things stand as of 2024, we also analyzed how those provider to population ratios have changed over time. We saw in our program's supply report, which looks at all 35 licensed healthcare professions, we saw there that the licensed clinical social workers, clinical social work associates, and the counselors and therapists are some of the fastest growing licensed healthcare professions at the state level in Oregon. So we were interested in knowing how that growth was distributed across the state. So to do this, we looked at the difference between the 2018 provider to population ratio and the 2024 provider to population ratio, and then calculated the annual rate of increase in FTE per 10,000 at the county level. So this rate of change reflects how steep the growth in behavioral health FTE has been for each county over our kind of study timeframe, which is 2018 to 2024. So here we see, so Multnomah is that top purple line, and it has the steepest increase. So it grew from a ratio of about 22 FTE per 10,000 in 2018 to 34.3 FTE in 2024. Baker County has the next highest rate. It increased from 6.7 FTE to 17.5 per 10,000. And then Wheeler County had the lowest. So it went from a ratio of 3.2 FTE per 10,000 to 0 in 2024. Could we go to the next slide, please? So it's important to note that these ratios are sensitive to small population sizes. So what I mean, so for instance, the change in provider to population ratio in Multnomah means that the county went from 1,800 FTE in 2018 to about 2,800 FTE in 2024. So the county gained 1,000 FTE. And so calculated out, as shown in this table at the bottom of the slide, adjusting for the county's population, that means that the annual rate of increase for Multnomah was 2 FTE per 10,000 residents every year between 2018 to 2024. Baker has the next steepest increase, so at 1.8 FTE per 10,000 every year. And this came from the county's licensed behavioral health workforce growing from 11 to about 30. So they gained about 19 FTE. So I just point this out to note, as you're reading through the brief or, looking at things, that there are smaller population rural counties that have seen increases in FTE for some of the behavioral health occupations, and that is promising and what we'd like to see. But it is important to note that those gains could be quickly lost if just a few providers left a certain area or stopped practicing or reduced their hours. Next slide, please. So here we have a bar for each county with the height of the bar representing that population adjusted rate of increase in FTE. So the height of the bar corresponds to the slope of the lines that were shown previously. Behavioral health FTE in Oregon as a state increased at a rate of 1.1 FTE per 10,000 every year. As previously shown, Multnomah County had the highest rate of increase at 2, so almost double the state's rate. And then on the other end of the spectrum, we have Harney and Wheeler losing FTE, and Gilliam had 0 behavioral health FTE. Next slide, please. So shifting gears a little, we also in the brief compare the racial and ethnic composition of the 2024 workforce with the demographics of the Oregon population. And we see that American Indian, Alaska Native, and Asian professionals are underrepresented in the workforce. And with underrepresentation for many of the disaggregated REAL-D race and ethnicity subcategories. White providers are overrepresented as a whole, and specifically providers who identify as Eastern European and Western European are overrepresented in the workforce compared to the Oregon state population. Next slide, please. Black and African American, Native Hawaiian Pacific Islander, and Hispanic and Latinx providers are also underrepresented. Mexican providers in particular are very notably underrepresented in the state's behavioral health workforce. About 10% of Oregon's population identify as Mexican, and Mexican professionals make up just 2.6% of the licensed behavioral health workforce. Next slide, please. So the REAL-D data collection and methodology, a kind of analytic approach, was implemented in the Healthcare Workforce Reporting Program surveys in 2021, and described earlier with the board's license renewal cycles. That means it took 2 years to get new data from all licensees. So this shift in methodology means that it is not completely straightforward to directly compare racial and ethnic composition of the behavioral health workforce over time. So for instance, the way that the multiracial category is constructed is quite different. The way the question is asked and the way the category is constructed for analysis is different under REAL-D. So, if that dramatic jump is a reflection of that methodology change. However, we did still look at the aggregated race and ethnicity groups to kind of make a rough comparison over time, knowing that there are limitations. And what we see is that the percentage of white providers decreased in all 4 behavioral health professions. So in 2018, about 89% of the licensed behavioral health workforce was white compared to about 81% in 2024. Though white providers still make up the majority of the workforce and are overrepresented. So during the same time frame, there were increases in the proportion of behavioral health providers who were American Indian, Alaska Native, Asian, and Black and African American. Let's go to the next slide, please. So again, another shift in gears. So the Healthcare Workforce Reporting Program survey asks if licensees if they currently have clients who receive their health coverage through the Oregon Health Plan. And we see that the share of behavioral health professionals who reported
I'm hoping Meredith will come off freeze here, but I'm just gonna talk through this slide until she comes back. So the share who do receive OHP or who have clients who receive OHP is in the blue color here. And as you can see, it varies quite a bit by occupation, with psychologists only.
like the percent of a provider's client volume that have coverage through OHP. Oh, I'm getting a message that my connection is unstable.
I think you're back now, Meredith.
Oh geez. Okay, okay. Should I start at the beginning of this slide? How long have I been
You can
unstable?
probably go to the next slide. I took over for a little bit.
Okay. Oh, thank you. So most behavioral health professionals report that they provide telehealth to their clients. Clinical social work associates have the lowest proportion, saying that they do telehealth, 66%, and then the counselors and therapists had the highest at 89%. On the survey, if a provider says that they provide telehealth, then they're then asked the top 3 counties where their clients are located. So almost 60% of the behavioral health telehealth providers reported that Multnomah was one of those top 3 counties. And these 3 top counties in the Portland Metro counties, Multnomah, Washington, Clackamas, they make up almost half of the percent of or almost half of the state's population live there. So many professionals across the state are likely providing care to clients in remote and rural settings, but those counties are likely not appearing in this top 10 list, at least in part due to the difference in population size. Let's go to the next slide, please. We also analyzed the percentage of behavioral health telehealth providers who listed the county of their physical primary practice location as one of the top 3 counties where their telehealth clients are located. And we found a high level of concordance between the physical practice location and their reported telehealth client location. So this kind of means that if a behavioral health professional is providing telehealth, the locations where their telehealth clients live tend to match the physical location of the provider. Let's go to the next slide. So to kind of summarize here, so we see that these licensed behavioral health professions are growing. The number of practicing professionals is increasing. The amount of direct patient FTE that they are providing is increasing. The largest increase is so the counselor and therapist FTE grew 85%. Clinical social work associates are right behind them with 84% increase. As of 2024, Multnomah had the highest concentration of behavioral health providers and also saw the fastest growth in behavioral health workforce from 2018 to 2024. Next slide. So there's a pretty large variety in the proportion of practicing providers who see OHP clients. So ranging from 34% of psychologists to 80% of clinical social work associates. Telehealth is very common. Most telehealth providers are reporting that at least some of their telehealth services go to clients in the county where the providers are physically located. And then finally, there's evidence that the behavioral health workforce is gradually becoming more racially and ethnically diverse, with the percentage of white providers decreasing from 2018 to 2024 in all professions, though the 2024 workforce is still not fully reflective of the population of Oregon. And as a final note, and the clinical social work associates are the most racially and ethnically diverse of these 4 licensed behavioral health professions. And we can do next slide. So that kind of wraps up the overview of the report. I know we are right at time. Dr. Hemmings?
Yes, hi. Thank you for this report. I've been waiting for it. A couple of questions. So when you mentioned that there's a decrease in mental health providers who identify as white, Does this reflect the general population in Oregon? Are we seeing a decrease in the number of people who identify as white within the state?
Hmm. That is a very important thing to know, and I do not have that
Okay,
information
all right, okay,
offhand. Yeah.
okay. The other question that I have is, do we know the type of organizations that these providers are practicing in? For example, community-based organizations versus group mental health practices versus the hospital system, health, do we know what sector they're working in?
So the survey does ask for setting, and we collect information on that. So that is something that we could look at to see if, the breakdown of setting types has shifted over time as well. We did not
That's
for
it.
this report, but we could.
That's important. The reason why I say that is because OHA is in the process right now of looking at making some changes as it relates to associates being able to bill Medicaid in 2026. And if you're going to look at the impact of that, you want to know where these providers are actually practicing, because the assumption why OHA is wanting to do this change is because there's an assumption that providers are not working in COA, certificate of approval organizations, such as community-based mental health programs, and are more geared towards working in group practice. So I think having those numbers would probably help in terms of the decisions around that. Um, the other thing I noticed was, the mention that CSWAs are billing, or 80% of their clients are Medicaid clients. And I think that needs to be factored into this decision around, if you know where they work, what settings they're working. I think that factors into the decision about the impact that it will have if you decide to remove associates from being able to bill Medicaid, right? If they're building such a significant number. And the fact that the CSWAs are more racially and ethnically diverse, I think leads us to really look at how we can create more opportunities to move them from being CSWAs to being fully licensed, right?
Mhm.
Thank you.
Thank you. And I will note in the chat, Christy, thank you so much. In 2019, 87% of Oregonians identified as white. In 2024, that number is 76.2%. So thank you for thinking of that.
Okay, so so it's reflective, right? It's not that, okay.
Okay, thank you. Probably have time. Actually, do we have any other questions? I don't see any hands up. Healthcare Workforce Reporting Program, folks, thank you very much for, again, an amazing presentation. I do want to take a quick moment. Let's go on to the next slide, I think, or I believe as usual, if you have questions, you can certainly reach out to the program staff. And next slide. Next slide. Okay. Let's go.
Hey, Jessica, can you advance all the way through the appendix? There is a final slide.
Go to the end. Okay. So once again, as we mentioned at the early part of the meeting, but since we've got a lot more people now from the committee, our educational webinar, August 13th at 9 a.m. will be on the nursing workforce. So I think a very valuable topic for more information. And then We will have a special meeting from 10 a.m. to 11, and that is a quorum required meeting. So we actually need to have quorum for that meeting to vote on the healthcare provider incentive program budget adjustments. So again, if you can make that meeting, please take the time. And then our next regular meeting will be September 10th, 9:30 to 12:30 in the regular slot. So thank you everyone for a really great meeting today. And I'm going to close the meeting unless anybody's got anything to add. Thank you. We can stop the recording.